Let's go.
Um, Great. Welcome. Welcome, everyone. Thank you for joining yet another CME. Uh, I really thank Dr. Vasavada. I couldn't have found a better CME chair than him. He is on the ball, making separate websites for next and next and next. We've got CMEs lined up. And thank you so much for getting this esteemed, great faculty together, young kids, young guys, which very close to home. I've seen one of the faculty grow up. I've seen him in diapers, I think. I'm looking forward to hearing from him. Yeah, there's an excellent topic which we have chosen today. Everybody needs to know what to do when this is a heart attack and stroke are the two common things where we need to act quickly. And today I'm looking forward to this wonderful talk. Again, this is a CME talk for educational purposes. The views expressed by the speakers are essentially theirs. They have endorsed that they are not going to promote any products or medications to keep this strictly a CME talk. And one thing I want everybody to know, is sometimes our flyer goes out late, but please understand that please keep this time, third Sunday of each month, year marked for CME at 2 p.m. Eastern Time, 1 p.m. Central Time. This is not going to change. We will have a CME again next month. Just one for your information. January we will not have a CME because we will be in Global Summit at that time. So we one month that Global Summit month and the convention month we do not have our CME. So apart from that, every month, third Sunday of each month at 2 p.m. Eastern Time, we will have the CME, and you will be notified of the content beforehand. I can give a sneak preview of next month's content. We went to this cruise in Patagonia recently, and it was a great trip. 200 people out there enjoyed it. We had excellent CME talks there. So it was Tarak's idea, so that why don't we actually have them speak, because a lot of people did not attend, did not and may have missed it. We chose without any bias. We just chose 3 or 4 speakers. I don't know exactly how many from those CME talks. So next talk will be assorted talks on different topics. Again, third Sunday of December at 2 p.m. It'll be assorted talks, and we will send you the flyer very soon. And we'll let you know. So just a sneak preview of next time's talk. So having said that, my work here is done. Over to Tarak for introducing the panel and the moderator, and I will mute myself. Thank you so much.
Thank you, Amit, and thank you for spending some time with us yesterday and today here. Like Amit said, every third Sunday, it was my mistake. I think I miscalculated it. But again, we'll do that. So next month, we will have it on third Sunday, which may be 19th or something like that, I think, or 21st. But today we have the talk on acute stroke and then follow up after that. I myself is an acute stroke victim, but lucky that nothing happened to me. It was a mild eye stroke and I could see well. But here, the moderator, I will give it to him and then he'll introduce the speaker, Dr. TJ Malpur. We both have worked in the same hospital at Huntsville Hospital for so many years. And he was also, I think, I heard his talk way back in one of the cruise. And he talked about the acute stroke, how it's evolving and changing. And I don't think Bagi was even in medical school at that time when we went to Baltics. So Dr. Malpur is a neurologist. He travels the world. He helps out AAPI. His wife, Vijaya, is actually doing more AAPI work than Dr. Malpur does voluntarily and freely. And their 3 children are wonderful kids. Like Amit said, I saw them growing up. And Bagi was my student. So again, so proud of him being here. So TJ, take it.
Thank you. Thank you, Amit and Tarak. Thanks for AAPI for doing this stroke seminar. why stroke is so important. I mean, it used to be the third leading cause of death in the United States, but then with acute stroke management and blood pressure control and secondary factor risk factor management, it dropped down to fourth and then fifth. Then the pushed it further down. Then COVID pandemic is over. Then now stroke is regaining its popularity again because it's gaining into between fluctuating between fourth and fifth places. And so it is still very important. Not only that, globally, it is the second leading cause of death, and it is leading cause of morbidity, I mean, disability, actually. That's why we want to reverse the deficit as much as possible. And even when they are left with the deficit, how the new modalities of the rehabilitation services are helping them to come back to their life and live independently, self-sufficiently. That's what Dr. Lopes is going to enlighten us on. So understanding the cerebral blood flow, concept of penumbra, all these helped us to minimize the stroke deficit, which Bagi Mulpur is going to talk about. So I leave it to him. So without any further I mean, I saw the stroke treatment changing. When I was started my practice in 1990, all we did is control or bring the blood pressure down, and even broke some procardia capsules under the tongue, and judicious heparinization. They were the mainstay of treatment at that time in 90s, late 80s and early 90s. Now it is totally opposite. We don't want to bring the blood pressure down. These are the things which will be enlightened later, but you can see the total change in the stroke management, and that's why we all should know what to happen, what to do immediately. So, so to introduce Bagi, uh, he's my oldest son. He's born in Chicago, so he's a Bears fan. But when we came to Alabama, we live in North Alabama, which is Huntsville, Alabama. He became a Tennessee fan. I'll tell you why. I don't know why. He might be able to tell you, but he's a very sports he fan, so he follows all these things. But after going to school and undergrad at UAB, he went to medical school at UAB and subsequently went to Cleveland, to the Cleveland Clinic to pursue his neurology career, which was a surprise until the dean told me. I didn't know that he was going into neurology. So then he met his life partner there. Then they moved to Miami, to University of Miami Medical Center, to do the stroke fellowship. Then they moved to Tennessee, Memphis. So he came closer and closer to Huntsville, which is his hometown actually. So in Memphis, he attended the Sims Murphy Clinic, the University of Tennessee Health Sciences Center, for his interventional vascular neurology and neuroradiology. It's a neurosurgical program, but both it's a combined program for neurosurgery, neurology, and interventional radiology. So he graduated from there, and fall of 2024, he came back to Huntsville, and we are so glad he came. And Monica, his better half, is, I mean, became part of our life. Now we do have a grandson too, Dylan, and we are much happier now. We feel we are complete, our life is completed. But now, uh, he is going to enlighten us about the acute stroke management, and I will introduce the second speaker after his speech. Bagi, you want to take over?
Yeah, thank you. I'm going to share my slides.
It's showing up. Double click to enter full screen mode. So,
Right, slideshow mode ready? Good.
yeah.
So thank you for the introduction and thank you for the opportunity to speak to everyone. When I was young, I grew up going to AAPI things and just eating food and everything. And now it's good to be part of the education curriculum. So I'm going to try to, in my lecture, describe all phases of stroke care from the beginning, ambulance sirens, ER, some of the acute interventions we do, but also the hospital course and lead on to rehab, and we'll transition to Dr. Lopes. Don't have any disclosures or financial interest and objectives. We basically will talk a little bit introduction. We'll be focusing on ischemic stroke. Obviously, hemorrhage is about 15% of strokes, but it's kind of a different scope of talk. But I tried to structure this lecture in a logical timing sequence from beginning to end. Just some basic background, living and growing up in Alabama, training in Memphis, doing surgeries on some of the sickest patients in the country. We all say that it's not false bravado. We have the highest rate of hospitalizations and stroke-related death and morbidity in the country. The southeastern United States is a stroke belt, and Alabama, Mississippi, Tennessee is the buckle of the stroke belt. Much different numbers compared to the rest of the country, but pretty prevalent everywhere. There are a lot of different ways people can have strokes. A little more locally about our state of Alabama. We, population-wise, are not that small of a state. People could think of Alabama and think almost nothing, all rural, but right in the middle of the pack, 24th out of 50 in terms of population. Well, what we do have is a significant shortage in neurology trained providers and significant shortage in hospital systems that are able to take care of stroke. Really, in our entire state, UAB in Birmingham is the only, I would say, fully comprehensive. There are about two or three other centers in the state, Montgomery, Mobile, and Dothan, Alabama, that at least have certification. But the rest of the state, north, east, west, we have a significant lack of providers. In terms of vascular neurology board certification, as you can see, our numbers are quite low, and most of them are centered in the Birmingham area. Um, so we definitely need to have effective systems to help counter the shortage. What is a stroke system? The idea is if you don't have the resources or you don't have the people who've been trained that I've been in a way that I've been fortunate to do, you have to have a program that is almost effortless. And it has to reach all areas, metropolitan areas like Birmingham or rural areas like Muscle Shoals, Alabama. Because what we find is that patients who have these conditions, they can be anywhere. They can be urban, they can be rural. Stroke is a common person's disease. It's not a rare kind of esoteric thing that kind of only affects the people on the second and third opinions in the office. It's an emergency situation that can happen anywhere, no matter where you are.
Buggy, is there a way your voice has some echo and some mild vibrations, but it may be hard to finish check it at this point, so it's okay. But just speak a little bit loud. So you are a soft-spoken person, I know that. So I think we can mute now. So. Can't hear you. Am I right, TJ?
The way you can hear me then, huh?
Yeah, it's okay. Just keep on going. That's okay. We tried, yeah.
Okay. Or actually, I can take. How about now?
Yeah, it's okay. I mean, that's okay. Yeah.
Actually, this is better.
It's better? Okay.
Yeah.
So part of a stroke system is about value-based care. The hospitals that have the ICUs and the beds, you want to triage and assess properly so patients who need those services are there, but you also want to empower regional spoke hospitals to take care of stroke. It's value-based from the hospital system perspective, but it also helps and pleases families. I can't tell you how many times I've seen patients from rural Alabama who are transferred to our hospital just because they have a stroke. They're about 2, 3 hours from their house. They didn't necessarily need to be here. As we go into the workup and the testing you do, a lot of hospitals can do this for the most part, and they're upset. They keep talking about having to be transferred all the way to downtown Huntsville or even heaven forbid Birmingham or something. So by understanding stroke, understanding the diagnostic testing and the interventions available, I think all providers, hospital medicine, ER, anyone who sees patients in a hospital should feel more comfortable after this lecture and knowing what to do with a stroke patient. So basic background on stroke, we're going to focus on the ischemic stroke, but that's about 87%. There are two interventions in terms of acutely treating the stroke. The medical intervention is intravenous thrombolysis. Those are blood thinner medicines. Used to be intravenous TPA or alteplase. Now more commonly is intravenous tenacteplase. And surgical basically involves opening up arteries, sucking blood clot out of arteries, stenting arteries. But the whole idea is stroke in the ischemic sense is a disease of restricted blood flow to a certain part of the brain due to a problem with one of those arteries. It's just plumbing, as I tell the patients. The time sensitive thing is not some kind of arbitrary rule or anything, but this diagram on the right illustrates kind of what we are trying to do. When there is a artery blockage, part of the brain is forever irreversibly scarred and damaged, even on pathology. If you were to open up the brain in a gross autopsy setting, that's what we refer to as the core, the infarct core infarct. The penumbra is a common concept that has revolutionized stroke care because surrounding that core, there's electrically stunned brain that is not functioning, that's making a patient not look very good. But if blood flow and reperfusion is obtained, that electrically stunned core turns back to functioning normally. In the moment, if you were to autopsy acutely, which would never happen, but for purpose of discussion, if you were to look at the brain tissue, it is actually normal brain tissue. It is just at risk of becoming core. So that's why the time paradigm becomes so important. So now we'll talk about stroke care from the beginning kind of to the end when we're transitioning to rehab. So pre-hospital stroke care is when the 911 ambulance, someone sees a patient who's not doing well, either at home or at a restaurant or even in a nursing facility, and they call the ambulance. And right then, ambulance has to make an immediate assessment in the field. I've ridden around during my training on ambulances, and what has to happen is the EMS providers are somewhat trained in ability to say, is this someone who is possibly or even somewhat likely having a stroke? And do we need to focus our efforts on getting him to a place that's able to take care of stroke? Or is it somebody who is intoxicated, drug abuse, low blood sugar, and they can just go anywhere? Because one thing I found in my entire career of coordinating hospital transfers and getting patients to where they need to be is the moment a patient enters the building of a hospital, if it's not that hospital, if that's not where they're supposed to be, it'll only be more inefficiency in getting them where. So that initial assessment is very important. There are some things called mobile stroke units. They involve even specialized ambulances that have CT scanners on board, but for most generalized ER kind of assessments, it's more of a clinical assessment. Once the patient's in the ER emergency room bay, it's about as time sensitive as it is. It's about as time sensitive as acute heart attack or even trauma. The only challenge is we don't have as easy and streamlined of a way to know what's going on. It takes a lot more subjective assessments, including neurological examination and imaging. The most important people in this when they get to the hospital are going to be the ER providers and the neurology providers or nurse practitioners in the ER, actively making the two pieces of the puzzle you need are the clinical exam and history, brief and focused, as well as imaging. All that process is, of course, to dictate acute management. So the clinical tools EMS and ambulance use are basically very simplified neurological exam. They all have the most common ones are Cincinnati pre-hospital stroke scale, Los Angeles stroke scale, and fast ER. But basically, they're three components. Is someone's face uneven? Is someone's arm weaker than the other side? Or can someone not talk? And if those things have acutely suddenly happened, they kind of trigger an automatic take to a stroke center. Now, there are a lot of reasons someone can have some look like that, but those are kind of the quickest and most consistently applicable rules to get someone to a stroke center. One of the biggest challenges in the pre-hospital and ER chaos is knowing actually when the symptoms happened. Unless there's actually a family member there able to tell the EMS, the ambulance people that, it's almost impossible to know. And it gets even harder to obtain once you get to the hospital. If a patient is at the house with their family member or loved one and they call ambulance, the ambulance knows the story. By the time they get to the hospital, the wife or husband of the patient's not there. They're getting in their own car and coming. You don't necessarily have the ability to talk to them right away. And there are a number of reasons why this is hard. I think one of the most frustrating reasons is you oftentimes don't even know the patient's name right away, right? That ER brings a patient who can't talk And if they don't have their personal belongings with them, so you don't know who the patient is. They come in as an unidentified patient, a doe, so to speak. Um, some of the things we kind of combat with this is ambulances kind of communicate predominantly by radio, like old walkie-talkie type radio, and they're actually not permitted to disclose the names of the patients over that because anyone can have a police scanner and listen to the radio. So that's an interesting thing I learned in my ambulance rotations because oftentimes if you had the patient's name, you could open up their chart on the computer, you could figure out what medications they're on, and you could call a family member. But it is tough, and it's a lot of chaos when you're trying to be efficient. So when a code stroke is called in the emergency department, the entire purpose of this is to efficiently triage patients who may benefit from time-sensitive stroke interventions. The purpose of a code stroke is not to perform textbook neurology. The purpose of a code stroke is not to even diagnose stroke or figure out what's going on. It's to figure out if a person has a decent likelihood of a disabling deficit that could be caused by a stroke. Anything beyond this creates inefficiency because you'll be getting CT scanners immediately. You'll be in the front of the line. You'll be hindering care of other patients in the ER. So a focused assessment is really important. Acute onset focal neurological symptoms are what trigger a stroke alert. So one side weakness, inability to talk, sudden vision loss, those are a stroke alert. Or if someone just really doesn't look good, don't know, they're completely obtunded, can't talk, someone who looks bad, for example, is a reasonable stroke alert. What is not a reasonable stroke alert, and this is where I think there are sometimes some misconceptions, is someone with a very minor symptom. Maybe they got dizzy, then got better, or had a little bit numbness of one hand. I'm not saying that can't be a stroke, but it doesn't need to be a stroke alert. Because again, the purpose of a stroke alert is to triage people who may benefit from stroke interventions. And stroke interventions only happen to people who have disabling symptoms. And then the other important part of the ER kind of assessment is the first thing is always like in any ER assessment, it sounds silly to say, but the first thing is airway, breathing, circulation. There have been many stroke alerts I've been to where a patient is actually having a pulmonary embolism, can't breathe, and everyone bypasses the ABCs and goes to stroke alert. So the basics always have to happen first, and you have to kind of be protocolized in that fashion. Neuroimaging is the next thing that dictates stroke alerts. You get a non-contrasted CT of the head, you get contrasted CT angiography as well as perfusion. One of the biggest other pitfalls is some people worry about kidney disease and if they can tolerate contrast. And what I'll say to that is if someone is truly disabled enough to where you've called a stroke alert and you want to consider them for stroke interventions for people like us who do mechanical thrombectomies, that none of that really matters because if you are a candidate for that, you're obviously going to want it. And if you're going to want it, you're going to need contrast. We can't do cerebral angiography without contrast. So a lot of times people get frustrated by the kidneys or contrast allergies, all of that. But if you're calling a stroke alert for the right reason, you think someone has a high pretest probability of having a disabling stroke, you should be able to bypass all that. And that's how it works at high functioning stroke centers. The first thing that we do is a focused neurological examination, a little more than the pre-hospital, but not as high as the ones that my dad would teach in his neurology clinical rotations. It's called the NIH stroke scale, and it basically tests motor, language, sensory, and visual functions, localizing it to each part of that brain. Now, it's become basically a statement on how bad someone's stroke is. In general, kind of keeping it very simple, if you have a high stroke scale number and the scale goes from 0 to 42, the higher you are, the more disabled you are, the more people consider doing interventions on. But that is always important to kind of make some context with that. That's not why this was invented. This NIH stroke scale was actually invented in the clinical research setting to measure how efficacious stroke interventions and rehab were, meaning they would take someone who was known to have a stroke and they would get their stroke scale. And as they progress through rehab or they progress through interventions and different medications, it would track their progress. So the reason I bring that point up is not all numbers are the same on this 0 to 42 point scale. What I've circled in red are functions that reach up to 9 points that are disproportionately affected by left hemispheric stroke. So it's very important to understand right hemisphere strokes and posterior circulation strokes. By default, will always have a lower stroke scale, but does not mean it is they are lesser of a candidate to be treated for stroke. So we'll talk about interventions now. The first intervention to be considered in stroke is a medical intervention. It's intravenous thrombolysis, and it's essentially a strong blood thinner. When I consent and discuss patients and patients' families for this, I oftentimes describe it as a Drano, a chemical solvent that you pour down your kitchen sink that is clogged. And that's the idea that they kind of understand a little bit. But the idea is within 4.5 hours, if you have a disabling stroke due to what we think is likely some type of blood flow, blood clot related issue in the brain, we administer it to increase your likelihood of improving. Now, I mentioned the NIH stroke scale before. This is even on the American Heart Association and indications, on label indications for the medication. Oftentimes, people think if your stroke scale is only 2 or 1, you just don't give it. But if you have complete hemianopia, which means you have a posterior circulation stroke and you have a right or left-sided visual field deficit, your NIH stroke scale will be only 2 from that. And you would want to think maybe you don't give it. But if you're a normal functioning, healthy person who drives to work every day, and now you have a stroke that makes you have a blind spot, you're disabled, you can't drive. Language is another thing. If all your deficit is language, but you can move everything, which can happen in stroke, you may only have a 2 or a 3, but no one wants to live like that. Sensory extinction is another one. It might be you can't feel one side of your body. You're less aware of the left side. It doesn't look, you can see someone like that. They don't even look like they're having a stroke. But they've shown studies when you have neglect, and neglect is an important thing in the rehab setting too, you will not be as high functioning as you are before. So in the end, it's not about the number. It's about if you have an acute change that we have a reasonable belief that could be a stroke and we have a medicine for it. Too often on the lower level, people look for reasons to quote unquote get out of giving TNK. But the way I look at it is if someone is coming to the hospital for an issue that we have a reasonable belief is a stroke, they're coming to the hospital for an issue that we have a medicine for you, we should try to give it unless there's some big reason why we shouldn't. So we'll talk a bit about some of the exclusion criteria, inclusion criteria. These things have changed over the last 4 or 5 years. There used to be a big list that you would check off. This patient has had this, so they can't get the drug. They've all become essentially viewed as relative contraindications now. With appropriate kind of counseling and kind of assessment of risk benefits, you will not get in trouble for doing it. So ischemic stroke in the prior 3 months used to be a contraindication, the clinical history contraindication. The idea is if you had a stroke recently, that stroke could bleed when you give the blood thinner. Now, all that is relative. If you had a very tiny stroke that you fully recovered from 2 months ago, you have almost no increased risk. So the idea with this is how severe. Severe head trauma, if you just hit your head on your bedside or you're hitting the head with an axe, it's a big difference. And there's not much severe head trauma is not a very specific term. So not immediately saying no and looking into this is important. From the ischemic stroke standpoint, that's one of the more lower level contraindications because if you had a stroke, most often you're on blood thinners well after it. So really, these days in the field, we don't view it as a complete contraindication. Prior brain bleed is another one people don't think about. The key is it's spontaneous. If you had a previous ruptured aneurysm brain bleed, if you had a prior traumatic brain bleed, if you had a prior brain bleed due to uncontrolled hypertension, none of those actually mean this medication is any more dangerous than you. The people who it is dangerous is if you have a truly spontaneous brain bleed without the typical risk factors that no one ever knew why, then I would say you don't want to give a TNK or a thrombolytic agent to. But you can see there's a big difference in this. And what we end up finding is someone has prior intracranial hemorrhage on their chart. That doesn't mean they're not eligible for it. You just need to be more sure and get some more information. A brain tumor, I would say, is overall pretty cautious. This is one of those where it's always a risk benefit pendulum. Most likely, I would prefer not to give it to someone with a brain tumor. Now, if they have a brain tumor that's a small meningioma that's not even actually in the brain, and they have a disabling stroke, it's definitely worth a conversation. And so the kind of theme goes on with GI bleeding. It's one thing to have uncontrolled GI problems, inflammatory bowel disease, always needing transfusions, or it's one thing to say by history you have a little bit of brown or dark stools. One is much more favorable to getting thrombolysis. Now we'll go for some more clinical exclusion criteria. Aneurysm is something that commonly comes up. A single unruptured aneurysm is not at all a contraindication for blood thinner. In fact, when treating aneurysm, oftentimes we put people on multiple blood thinners to properly treat the aneurysm. I have a personal experience with this. One of my patients who I was following for an aneurysm in my outpatient setting, she recently, earlier in the year, about it, when I first started in Huntsville, she came in with a stroke and nobody gave her intravenous thrombolysis. And so for the last 16 to 18 months, my entire Huntsville career, I've watched her slowly recover from the stroke. It's caused her significant disability for the last year and a half. And now she's finally at the point after rehabilitation where we're about to treat the aneurysm. So if you put yourself in her shoes, she had a stroke, went to the hospital at the right time, did not get the medicine for that condition for not a real reason, and then it caused her to not be able for me to treat her aneurysm due to the disability it caused. So we have to be more open-minded in these. The other thing I'll kind of touch on is aortic arch dissection. That is something that can come up. Someone can have a major aortic dissection, which is causing stroke because it's extending up into the carotid arteries, but also down into the aorta. Those are ones where if they're going to be going to urgent cardiothoracic surgery or you want to be cautious on blood thinners. So that's one where you always have to be in the back of your mind looking at your CTA very closely because the CTA in the stroke setting includes the top of the aorta and aortic arch. So now we'll talk about endovascular. This is a field that has brought a lot of excitement to the field. Basically they're big strokes that people would never do well from, and now we've gotten pretty good outcomes. So this is essentially surgical removal of the clot. When they published these landmark trials in 2017, it was right after I graduated medical school, but the number needed to treat was 3, which is the lowest medical or surgical intervention you'll find in any major clinical trial. Now, what I will say is that was amazing because number needed to treat is 3. The reason number needed to treat was so amazing is the natural history of this condition, a major large vessel occlusion, is so poor. With the number needed to treat is 3, that still means 2 out of 3 won't achieve a good disability outcome. I feel like in our cognitive bias, we think it's so amazing when we see someone who looks so bad, get a thrombectomy, looks good within the next day or two, but 2 out of 3 people don't get that. So it's important to set expectations appropriately. Now, at this point in my life, I've done mechanical thrombectomies, acute stroke intervention at least 200, 250 times. So I've seen a lot of people who don't get it too. And I always feel like the rest of the hospital, family, we're expecting the patient to turn right around. And that only happens 1 out of 3 times. And it happens 1 out of 3 times at 90 days, not the next day. So in those trials, of course, they pick pretty healthy patients. They pick the ideal candidates. In the real world, we have people with significant comorbidities, already pre-existing disability. So I think, it's a beautiful thing. It's actually what got me from neurology interested in the surgical specialty, but I do think appropriate expectations is very important. Now, oftentimes in the ER, when we're deciding to do these surgeries on people, sometimes people have essentially an advanced directive. They know they're already on hospice, and I tend to shy away from that. Now, what happens most often is no one knows what the patient wants. Now, we might feel that this patient already has really bad heart failure, cancer, probably won't do well. My expectation or my approach to these settings is in the acute setting, unless they've been explicit in goals of care, I try to offer treatment because asking in this setting, taking more time, all it does is lower the likelihood of someone doing well. Now, realistic, if they don't pick up well, they're continuously disabled, their hospital course is not going well, I quickly will pivot towards comfort-based approach. But really, if you have a large vessel occlusion, and unless you clearly specified coming in that you're on hospice or you have certain advanced care directives, I think in general, I would recommend offering it because no one's going to decide in the heat of the moment that they don't want it. So I'm going to describe 2 recent surgical stroke intervention cases I have to kind of give you guys a little bit of a background on how it looks, what it looks like, what we do, and that'll segue us into kind of etiology of stroke, and we'll be transition towards the end. But I think these 2 cases are kind of a good setup for it. So case one is a 66-year-old healthy female. She was at lunch. She suddenly couldn't speak right and right side of weakness. By the time she got to the ER, they got better. So no one gave her tenactoplas. No one, thought she needed anything. But all of a sudden, she went to a stroke scale of 25. So initially, her stroke scale was 0, then got better. Then all of a sudden, she immediately plummeted to where she could barely keep herself awake or move anything. This is a CAT scan on the left image. We'll see it's kind of one of those, many of us have seen this. It's CT scan with no acute intracranial process. Now her CT angiography in the CT, this is a CTA of the head and neck. And do you see my pointer or no? You do? Okay. So this is the basilar artery where my mouse is. And as we'll see right about here, this contrast blurs out into a clot. So that's a basilar artery occlusion. So what we did was we took her to the lab. We via transradial approach, and it really is amazing the kind of things we can do in people's brains. This procedure starts with a 21 gauge needle to the artery. So it's essentially like a line or a peripheral IV sized needle stick into the artery. We access the radial artery and go up the arm. This is now we've gone up the arm into the shoulder. You see my tip of the catheter here. This is the right vertebral artery, which is the highway to the back of the brain basilar artery. Using X-ray guidance, this is called a roadmap. It shows us how to navigate our catheters and wire. We access the vertebral artery and we do this picture where we see this basilar artery occlusion kind of the end of the basilar artery. And this is the view on the lateral exterior, seeing a clot at the top of the basilar artery, explaining her symptoms. So this is a view of exactly where my mouse is. That is the clot. You kind of see it in a faint outline of the arteries that are trying to get blood flow behind it.
Mm.
By getting the catheter up there, then we do essentially put a vacuum suction on it. And now you'll see we've reperfused the artery and you see all the distal basilar artery vasculature. So this is kind of a quick before and after. Before is on the left, after is on the right, after the thrombectomy is completed. In the natural history for basilar artery occlusion, if you have a severe stroke syndrome, about 65% mortality with this condition. So this is kind of the end outcome. This is the clot that we removed. It was on our table right after. This is the MRI, and you'll see on the MRI that she basically just had a tiny little residual stroke. This is what we would call the core, as I talked about before. But if we were to have not treated this condition, essentially every part of this MRI I've showed you could have been a stroke. This is her follow-up in the clinic, completely normal, no symptoms. It's the ideal 1 out of 3 picture perfect case. Now she had atrial fibrillation, so we put her on anticoagulation for stroke prevention. So that's our first basilar artery case. Our second basilar artery case here. This is again a 70-year-old person. Sometimes, for whatever reason, I do consider posterior circulation basilar arteries to have some fluctuating of symptoms. This person initiated at stroke scale 7, improved to 2, went back to an 8. So we look at our neuroimaging closely. Again, a negative normal CT of the head. And now we'll pay attention to that very same basilar artery again. This is the back of the brain, basilar artery, and we'll see it begin to occlude right about there. The contrast goes out. So that's what we're looking for. This is a picture coronally projecting, but you can see anytime you have these kind of curves in your arteries and everything, it's kind of a hidden indicator of vascular disease. A much different picture than the picture perfect anatomy on the last case. So we started this procedure off transfemorally, and right away we see this is about a 180-degree loop. So this person clearly, unlike the other person, has pretty significant vascular disease. Now we do our catheter injection from the vertebral artery, showing our basilar artery occlusion. Same view here. Now, this kind of highlights the difficulties when you have vascular disease like this and greater curvature and tortuosity of your arteries. This big kind of turn you make with the catheter. Remember, all this we're pushing from either the patient's groin. The more turns there are, the more resistance in the system there is. So what actually happened here was we could get into the vertebral artery, but we were unable to access the brain. Everything just kept falling back down. So then I went over to the left arm. Sometimes left arm provides you from a different vantage point. We're not all the way from the groin here we had a more favorable angle to access the intracranial circulation. And then this is the clot again, what we were looking at, what we were dealing with. Now we did a thrombectomy and we opened the artery up. As you can see, it's a much different picture than the last one. The artery is open and there is flow, but as you can see, it's a horribly diseased artery. This is not like an atrial fibrillation, fresh clot from the heart. This is a chronic artery filled with calcium and hardened by hypertension and smoking, and there's barely a lumen even after taking the clot that was acute out. What we did next was we locally put some intravenous TPA right into the artery. It didn't really change it, maybe marginally improved it, but pretty much still pretty diseased. So at this stage, we're left with this is a patient who we've reperfused the brain, but this is an artery that no one has good confidence that will remain healthy. In fact, most likely what we believe is it'll close again. So now, while in the brain, while we're doing this, what we did is we crossed it with a wire. We put a stent right across the stenosed segment to keep it open. So reconstructed, revascularized this artery, basilar artery. And then this is our next pictures. Now we have a much more stable, secure looking. And this is a powerful intervention, what we've done essentially from a 21 gauge needle stick into the radial artery. And so here are the three pictures. The first one is before doing anything. The second one is after taking the clot out only. And the third one is after we stented it to preserve it. This patient also, fortunately, this is a significantly higher risk procedure, but we were able to do pretty well and minimal stroke burden on this patient's MRI. This patient did decent, had to go to a rehab facility afterwards, but in then was right on track for kind of good functional outcome. So after you do all these interventions, where are we now? We talk about the hyperacute phase of the hospitalization. They're usually in the ICU. There are two main things we're watching for in the ICU. One is now that we've opened up an artery, there's a concept called reperfusion injury, which manifests as hemorrhagic transformation. Many of you have seen on a CT scan or MRI, the radiology says hemorrhagic transformation. What that is reperfusion injury. And the way I explain it to the patients is pretend you starved for 5 days, then you went to the all-you-can-eat buffet and your stomach will hurt after. And that's it helps them understand that. So controlling blood pressure is really the most effective medical intervention we have to this. So being in the ICU is kind of a mainstay of that. Number two is, unlike the cases I showed you, sometimes we're left with, despite our best efforts, we have a big stroke. The next 3 to 5 days after having a big stroke is when your brain cerebral edema is at a maximal. So you can have a secondary injury after the stroke. Essentially, your stroke is one thing, then it swells and almost acts like a bigger stroke because the swelling makes the size bigger. What that can do is essentially brain herniation. It pushes the brain. There's no other room in the skull other than down the foramen magnum into the spinal cord. So the brain goes down the drain. It kind of causes cardiorespiratory compromise. Big strokes like this, medical intervention is essentially hypertonic saline, mannitol. The idea is you're drying the brain out. The parts of the brain that don't have the stroke, you really try to reduce the amount of water content in it so there's more room for the brain to go from left to right rather than down. Surgical is a bit more barbaric, but very useful therapy. You take off part of the skull so the brain can swell sideways, not down the foramen magnum. Now it sounds dramatic and it sounds like you would never want that to happen to yourself, but it can be a tool in the right setting with the right expectations. It will not reverse the stroke you have. It'll stop the stroke you have from killing you and give you a chance over a long-term recovery to potentially gain some independence back. These are numbers from two of the larger hemicranie trials. You have a 50% chance of at least living at home long term. You might have disability, you might have some resources at home to help you, but living at home is oftentimes considered a win rather than a nursing facility. Now we'll talk about after the interventions, after the ICUs, what we do in the hospital. And this affects everyone, hospitalist, internal medicine, cardiologist, anyone, most likely anyone who's set foot in the hospital has taken care of a stroke patient. Oftentimes it's called a routine stroke workup. I really don't like that phrase because saying it's a routine stroke workup means we lack purpose in it. Every single test we do as part of a stroke workup has a purpose. The CT angiography of the head and neck is looking for large artery atherosclerosis. That means, do you have major atherosclerotic stenosis in your neck arteries or your brain? And that was case two. This patient had stenosis pre-existing of the major brain arteries. Usually in the brain arteries, unless it's so severe or it's a recurrent stroke, medical is prevented. You usually do double antiplatelet therapy for 3 months, high intensity statin. And if it's in the neck, though, especially the carotid arteries, that's where you come into carotid endarterectomy and carotid stenting. Now, a CTA for the head and neck is mandatory if you're doing a good stroke workup. Sometimes we do carotid ultrasound, sometimes we do non-contrast MRAs. As somebody who does surgery on these arteries, none of those give you good enough information to decide if a patient needs surgery. So if you have a patient with a symptomatic stroke, you need to get contrast-based CT angiography for the head and neck unless you have a strong reason not to. Then cardioembolic is one of the other more pertinent risk factors. These are people with atrial fibrillation, endocarditis, or severely low reduced ejection fraction heart failure is actually considered an independent cardioembolic risk factor. So that's actually an indication for anticoagulation even despite atrial fibrillation until the heart failure reaches above 25% ejection fraction. Then your standard risk factors are your lipid panel, your LDL, your A1C. So these are kind of what builds up in arteries. Extended testing, and usually this is driven by a neurology consult, but it can be anything from cerebral angiograms to look for dissections, autoimmune testing, hypercoagulable testing, looking for neoplasms for a hypercoagulative cancer. Those are all kind of the extra things. But the bread and butter are these three things: your cardiac workup, your CTA to look at the arteries, and then your kind of vascular risk factors. Now we'll talk about blood thinners as kind of one of the last main points of my talk. We view stroke prevention as kind of our biases always go towards blood thinners. We think blood thinner is what prevents stroke, which is obviously is a main part of it, but it's not the only thing. Basically, breaking it all down, the most common kind of strategies are antiplatelet monotherapy, just one thing, aspirin or Plavix, double antiplatelet therapy, or an actual anticoagulant. And it's important to be right about these. So everyone is going to be on at minimum aspirin or antiplatelet monotherapy. And there really is no difference between aspirin and Plavix in stroke. Now, I understand in cardiology, there's a little bit of preference to clopidogrel. Aspirin 81 or aspirin full dose, there really is no data that says any is better than the other one. There is some pharmacological data that it's weight-based effectiveness. So I kind of generally kind of roughly estimate if the patient looks like they're over 180 pounds, I do a full dose, but if they're smaller, I do a baby dose. Double antiplatelet therapy, the two indications for this are one, if you have a small stroke or TIA, there are two trials that came out in 2020 called the Point and Chance trials. You basically, they showed a short-term benefit in double antiplatelet therapies, but if you carried on for longer than 21 days, there's increased bleeding risk. And, for reference, the number needed to treat trial for that trial was 62. So it really shows the power of mechanical thrombectomy having a number needed to treat of 3. But basically, you load them and you put them on double antiplatelet therapy. By the book is 21 days. I oftentimes do 30 days or 1 month so the patient just remember it easier. But it is important not to just have it continued in perpetuity. Now, if you have symptomatic intracranial large vessel stenosis, so these are intracranial internal carotid M1 segment of your MCA, basal artery, and vertebral artery, it's a longer course, usually 3 months, and then you're kind of following up and re-imaging some of that stuff. Now, it's important our CTAs have gotten so good, they will label even smaller vessel stenosis, PCA, M2. That does not necessarily mean you need to be on double antiplatelet therapy. Avoiding, and I find this oftentimes in my outpatient practice, avoiding unnecessary blood thinners helps the patient too. These are the patients who need to have a tooth pulled or a spine surgery or something else that's affecting their quality of life. And everyone's afraid to do it because all of a sudden now they're on 2 blood thinners because they have to have a stroke. Anticoagulation are kind of the cardioembolic risk factors. We talked about atrial fibrillation and reduced ejection fraction, heart failure being the most common. Now, one thing that's important to know in stroke is all these risk factors, you truly only have to be on anticoagulation only, whether it be apixaban, rivaroxaban, or even Coumadin. You don't need to be on that plus aspirin. That's only an increased bleeding risk, unless you have another medical reason like coronary artery disease with stents, peripheral artery disease. You may need to be on both. But too often I see stroke patients that are on both an anticoagulant and an antiplatelet therapy, and almost never do they actually need to be on them. The other things are your cholesterol, and I think statins have recently, especially in the political climate, become a lot more controversial. So LDL less than 70 and statin on discharge became kind of a metric in stroke outcomes and people checking compliance with stroke centers, and it's caused everyone to be unnecessarily prescribed to be on statins. You really only need a goal that low if you actually have atherosclerosis in your arteries on your CTF, the head and neck. So I oftentimes actually don't put people on statin if they've had an atrial fibrillation or cardioembolic stroke. And as all of us as doctors, it makes perfect sense. But some reason in the hospital, everyone thinks you have to be on a statin. Is at our hospital, Huntsville Hospital recently, they have all these numbers, and I actually I actually am proud of this, but I'm the least statin prescriber of all the neuro hospital stroke doctors in Huntsville Hospital because I do it individualized based on the patient's needs. And I think when you do that, your patients are more likely to be compliant to what you recommend them because it shows that you're listening to them and individualizing your attention. Diabetes, of course, everyone knows about diabetes. Plenty of people on this talk know more about diabetes than me. The other thing is lifestyle, diet, and exercise. Not everything is a pill, and too often we want pills and stents and all this stuff. One of the major trials in stroke was called the Sampras trial, and they evaluated medical management and lifestyle versus intracranial stenting. And not really to break down the trial, but one of the interesting things about that trial is the medical management and lifestyle arm. They actually had coaches talk to these patients and tell them what to eat and check in with them, just like a pure lifestyle coaching visit. Now, that would be a great luxury if we could have that, which we don't, but it does show there is a lot of power in stroke prevention behind lifestyle, exercise, and diet changes. Now, outpatient follow-up is critical in stroke. We always think of stroke as a inpatient only disease. I really believe about 50 to 60% of the work in taking care of a stroke patient is outpatient. Whether it be someone who had an embolic stroke and nothing came up on their echocardiogram or they don't have atrial fibrillation, you can kind of do further advanced testing, hypercoagulability, transesophageal echocardiograms, all of those which would be overkill to do in the hospital. You don't need to have someone in the hospital and do every test, but down the road, you can kind of continuously refine your prevention strategies and do extra testing as needed. And of course, a big thing is avoiding extra blood thinners. Too often, someone leaves the hospital with a bag full of medicines that they most likely don't need some of them. These people, even when they recover from the physical symptoms, there's a big effect a diagnosis of stroke has on you. It makes you less likely for someone to do other stuff, other procedures to you. So if you're someone who's suffering from really bad cervical spine arthritis and a spine surgeon wants to operate on you, all of a sudden they won't do it because you've had a recent stroke. So a lot of my work in the stroke outpatient setting is talking to other doctors, clearing people at the right time, having them return to work. And that's kind of in the end, when the goal of taking a patient with a stroke is to increase your quality of life, return your quality of life. If you don't do all this, if you only have an inpatient hospital-based approach, you are not actually doing it. And the main phase I didn't talk about was rehab and what goes on with rehab at all levels. So I want to turn it over to maybe my dad, then Dr. Lopes. But we'll do questions later or what?
Yeah, unless whatever Dr. Malpur wants, that Dr. TJ Malpur wants.
Okay. I think we should let Dr. Lopes also finish her presentation. And you don't have any emergency to go, Buggy, do you?
Not right now.
Okay, okay. Then why don't we hold on
I'm
to the
call for neuro intervention right now. So luckily so far.
Yeah, Buggy is on call right now, so thank you.
Okay, and it's my pleasure to introduce Dr. Lopes. Dr. Sarah Lopes is a native of
Hey,
Tylertown.
can you get out of the thing? Yeah. Stop sharing, Buggy. Yeah.
Tylertown, a rural community in southern Mississippi. She earned her associate arts degree from Jones County Junior College in 2013, followed by Bachelor's of Science in Biochemistry from Mississippi State University in 2015. You know, Mississippi is right adjacent to our Alabama, and we fight with the football. Anyway, that's a different story. She went on to complete her medical degree at William Carey University College of Osteopathic Medicine in 2020. Dr. Lopes completed her residency in physical medicine rehabilitation at the University of Alabama at Birmingham in 2024. And that makes us feel much older. I graduated in 90, 81 and finished residency in 1990. Where anyway, she served as the administrative chief resident during her final year. Her passion for the program and its mission led her to remain at UAB as a faculty member. In her clinical role, Dr. Lopes primarily cares for patients with stroke and limb loss in the inpatient rehabilitation setting. She's also deeply committed to global health and has participated in medical mission work with Kenya, Malawi, and Honduras. Outside of medicine, Dr. Lopes enjoys spending time with her two young children, Asher and Virginia, and playing board games with her husband. She's an avid baker, especially sourdough is her favorite, and loves spending time outdoors. Here, Dr. Lopes for you. Dr. Lopes, you want to take?
Yeah, here I am. I just had to unmute. So yes, I am from Mississippi, but like Boggy, I am kind of a Tennessee fan. My husband was the mascot for Tennessee, and so, Mississippi State is never good at anything these days. So guess I'm a Tennessee fan now. Um,
Oh,
but I'm so happy to talk to you guys about just what is PM&R? No one knows what it is. It's kind of a mystery to a lot of people. And then one of my favorite topics, just stroke recovery. Um, Let me go forward. I unfortunately have no financial disclosures. Maybe one day. So overall, just kind of talking about a basic understanding of the specialty of PM&R. It's a very broad specialty, and so I think it's good for you to kind of understand a little bit about our angle, so that way you can kind of see how we evaluate patients and look at them a little bit differently than neurologists do. Our training is different, so we view the patients with the same diagnosis from a different angle to give more comprehensive care to people that have suffered from strokes. Just a kind of basic review of considerations of post acute rehab after a stroke. Where do they go? Do they go to a nursing home? Can they go home? Do they go to IPR? And then discuss complications of strokes that we normally treat, and then understand the process of motor recovery because that is what frustrates patients the most that I see if they don't have aphasia. And so that's kind of something very separate. We won't spend a lot of time on that because we don't have a lot of good tools to help with that yet, but we'll get there. And just kind of an outline, just introduction, our team at UAB, and then just kind of different qualifications for different types of rehab, and then stroke comorbidities, motor recovery, and then questions. So, what is PM&R? I have married my husband in medical school, and he still can't tell you what I do. And he tells people I'm a mix between a neurologist and a physical therapist. And that is not it, exactly. So, PM&R is physical medicine rehabilitation or physiatry. It's a medical specialty focused on prevention, diagnosis, rehabilitation for people with functional limitations. The limitations can be due to a congenital disformity, an injury such as a stroke or a spinal cord injury, or just disease pathology that has kind of taken over their life. So think about osteoporosis, or if they have spinal canal stenosis, now they have a spinal cord injury. It's a very young specialty, and so the first department was actually in Temple University in 1929. It was the two kind of fathers of PM&R are Dr. Frank Cruson and Dr. Howard Rusk. Dr. Howard Rusk, he is more pivotal in actually creating the American Board of Physical Medicine and Rehab that was established in 1947, and he actually created the first like PM&R institution. And so that was the Institution of Physical Medicine Rehab in New York. It's now the Rusk Institution at New York, NYU. Um, and so just so that you know a little bit about us and what we do. And so this is our team, and I kind of want to just show you the photos so you know what we look like, but also so that you can see how broad our specialty really is. So we have 3 spinal cord injury fellowship trained. You can do fellowships in spinal cord injury, traumatic brain injury, sports medicine, pain medicine. Um, Burn is kind of a non-ACGME fellowship, and pediatrics. I didn't add the peds people because a lot of kids don't have strokes and they're their own department. So we have spinal cord injury, we have APPs that work with us, we have our brain injury person, Dr. Taranishi. She all have met her, maybe. She's also our consult stroke director, and she goes around giving lectures about PM&R and promoting us as a department. And then we have our sports, our pain. Dr. Powell does cancer, congenital research, and then we have Parkinson's, another brain injury person. Um, and so we also have a new rehab hospital, and so that's been really cool. It's been in the making. Spain Rehab, our original building, was completed in the 1960s, so it's getting a little old. It was only 49 beds, and so we really wanted a new space, and so it just opened. It opened in August, and it's now 78 beds. We have 3 floors at the very top of the building. So the building is 11 stories. The first 4 are all parking. The 5th floor is like a hospitalist unit. The 6th floor is all education. They have some really cool educational labs. And so we're looking forward to doing some educational things. So like Botox training or just other educational things for residents and fellows in the future. And then the top 8 through 10 are all rehab floors, and they're divided by diagnosis, which is awesome. The very top floor, which I work on, I like to say stroke is at the top because it's the best. And so our stroke floor is number 10. Then we have our spinal cord injury floor and our TBI. And it's just so great because the floors have been designed for the diagnosis. And so, for example, our stroke floor has more speech therapy rooms than all the other floors because that's kind of a number one thing with people with left MCA strokes is they have aphasia. And so we want to work on that. And so post-acute rehab options. So when people say they hear, oh, they need post-acute rehab, the number one thing that people come into mind is, oh, well, they need IPR or inpatient rehab. But that's not always the case. So post-acute rehab is just a blanket umbrella term for different rehab options in the setting after acute care. So post-acute care. And so kind of this is a good diagram. Hopefully y'all can see my mouse. This is a really good diagram to kind of show how patients move through the healthcare system and some different options of acute rehab. And so you have the injury. So in this case today, we're talking about strokes. So stroke, you have your stroke at home. The emergency department, or not the emergency, EMS picks you up and takes you to the emergency department. Here, you have your workup, you're in the acute care stay, and now it's time for you to discharge. Where do you go? That is the big question. That's one of the number one reasons why we as a department are consulted in acute care is to help the primary team determine what level of rehab someone needs. I work very closely with our stroke neurology team at UAV, and so we get automatically consulted anytime someone has a Rankin score of 4. And so if you don't know, a Rankin score just tells you how debilitated someone is. So 0, they have no deficits. 6, they're dead. 5, they're bedbound. And then 4, they can walk, but they need assistance. And so those are usually the people that their family members don't feel comfortable taking them home. And so it's my job to help the primary team say, okay, well, the family can't take them home, but what are really their options? And so at the top, this chart is going from highest intensity to lowest intensity from the amount of hours of therapy you do per day. And so at the top, we have acute inpatient rehab. That's where you do 3 hours of therapy a day. It's not all at one time, but patients have to be able to do that. And so when we're evaluating patients for that, we look at also what were they doing before, because the most common reason people have strokes is age. That's the number one non-modifiable risk factors. And so as people age, they typically do a little bit less throughout their days. And so we try to get a really good history from family and the patients about what they were doing prior to their stroke to see if they can tolerate 3 hours of therapy a day. If you have a sweet little old lady who's 95 and she just kind of sat in her rocking chair on the front porch all day, she probably couldn't do 3 hours before her stroke. So that really wouldn't be the setting for her. That's kind of the number one reason why people can't come to IPR is either therapy tolerance and they just can't do that intensity. A step down is subacute rehab at a skilled nursing facility. That is where you do 21 days. And how I describe that to patients as a different from inpatient rehab to subacute is it's a longer duration but less intensity throughout the day. And so it's typically always 21 days, whereas inpatient rehab, our average length of stay is 10 to 14 days. So patients are there for longer, but they don't have as much every day. And so they're able to tolerate it. And some patients go from acute rehab to subacute rehab. And then Alabama doesn't have any residential rehab programs. Those are kind of like halfway homes a little bit. We don't have any here. And then people can go home. So if people are doing well enough or their family just doesn't want them in an institution, they will take them home with home health or outpatient therapy. We typically kind of say home health for people who don't have reliable transport. If they can't really get in and out of a car easily, those are reasons why you would do home health and then transition to outpatient therapy. And then they have the outpatient, which is individualized therapy programs, day programs. Some states do have day programs where while your family member is at work, you go and you hang out at that facility and you do therapy there. Again, we don't have that in Alabama. And then after that, when we follow up with people in the clinic, this is kind of where we are. And so we set people up with vocational rehab. These people had lives before strokes. And so how do we get them back to work supported? And then special education. So that is for sometimes we have college students or older individuals that are going back to college and they need special learning plans. And so we help the teachers and we add recommendations for what we think they need based off of neurocognitive testing. And then we have support networks, support groups, recreational groups. If you haven't heard of Lakeshore Foundation in Birmingham, for anyone kind of in that area, it is an excellent resource for anyone with disability, not just stroke. They have all adaptive gyms. They have some day programs. They have just community support groups. And so it's just a really beautiful community. And these are some additional slides talking about the criteria. And so for IPR, inpatient rehab, you have to require 2 of the 3 therapy disciplines. And so that's PT, OT, and speech. Some people with our amputees, they get a little bit confused about is OMP a therapy discipline? It is not. It is just PT, OT, and speech. If you've had a stroke, most of the time you automatically qualify for those. So it's very easy for stroke patients to get into IPR just because of how affected they are from their stroke. And like Dr. Mulpour said, it is a number one reason that people are debilitated throughout the world. And so we get a high volume of those. Like I said, you have to be able to participate in 3 hours of therapy a day. That can look a little bit differently. And so, like someone that has a very large left MCA stroke, they're going to need a lot of assistance with things. If you have someone with a higher BMI, I know they're going to you have like levels of therapy. And so, if someone is dependent or they're requiring total assistance from the therapist, but based off of their diagnosis, that makes sense, we would accept them. But if for some reason you have someone with a much smaller stroke and they're still requiring a lot of assistance, then you kind of think of, well, maybe this person really isn't a candidate. So it looks different for different patients. And even if someone has the same type of stroke, it can look vastly different depending on, like I was talking earlier, what they were doing before their stroke. So someone that was working completely independent, if they have a very large MCA stroke, they may have a little bit more functional reserve than someone who is kind of just hanging at the house, not really doing a whole lot. They have to require medical oversight by a rehab physician. And so all of our stroke patients usually qualify for that because you usually have comorbidities that go along with a stroke. The only time this kind of comes into play is mainly for our polytraumas. If we have like young people that have fractures, if you just kind of break a leg, you don't really qualify for inpatient rehab. You don't really need medical oversight from a specialized physician. And then you have to have other miscellaneous things. You have to have the ability to make functional gains. And so if someone was on hospice before this, they may not be an inpatient rehab candidate because they may not make the functional gains or the family, that's not really their goal. They want them to be comfortable versus, you have to have a rehab diagnosis. And so we have the CMS 13 here. This isn't all of them, but in order to admit to inpatient rehab, you have to have a certain diagnosis. We can't just accept anything. And so you have stroke kind of at the top of the list. And then, because Alabama, we are in the stroke belt. I did see that Mississippi was a little bit worse, made me a little sad, but I guess I'm an Alabamian now, so. And then subacute rehab, you still have to require two of the three therapy disciplines. And so if you only need OT, or a lot of times people really only need speech, they can go home and do that outpatient. And so, or home health. You don't really need to be institutionalized for that. And you have to be able to tolerate 1 to 2 hours of therapy a day. And again, that looks different for different diagnoses. And then you don't have to require oversight from a rehab physician, but you do have to have something medical that can't be managed at home. So, a lot of times for our stroke patients, they already have diabetes, high blood pressure, heart disease, medication management. Very rarely do you have someone that's super young that has absolutely nothing else going on besides just a stroke. It's pretty rare. Every now and then we do get them, but still. And I think another thing is a lot of people get really nervous when you suggest a skilled nursing facility because they get a bad rap, and for good reason. They're not all created equally. So when you're counseling your patients on this, if you really think they would benefit more from a skilled facility versus subacute, I always tell my patients and their families, I tell their families, not the patient, because they can't go, but their families to just show up at the facilities that they're accepted at. Like if they have a number one choice, just show up. Don't call the facility that you're coming, don't schedule a visit. Just show up, ask to talk to the therapist, ask to talk to the nurses, ask to talk to the managers. That way they feel more confident about their patients going there. And sometimes I get the question of, oh, why wouldn't it be good for everyone to try IPR before going to a subacute? And honestly, for patients that really can't tolerate the intensity, it's more defeating for them and they end up with more depression and more setbacks than actual good. And so you really want to meet patients where they're at because stroke isn't just a physical thing, it's emotional, it's mental. And so they've gone from being able to do everything that they need to now they hardly can do anything. And you don't want them to feel worse about their disabilities by trying to make them perform at an intensity that they just can't. And so typically what we help the primary team do is we look at certain stroke complications. And so here we have the different diagnoses that we see for stroke. I have aneurysmal rupture as an asterisk because we treat it a little bit differently in our department and at UAB. So they aren't admitted to the stroke service. They're actually admitted to the neurosurgery department, and that's the same for subdural and epidural hematomas, and a different provider actually sees them. So I don't actually care for those patients. I only care for really hemorrhagic stroke, big IPHs, and ischemic strokes. And so that's why I have an asterisk there because they're a little weirder than just like your run-of-the-mill stroke as far as from a rehab standpoint. They perform and heal more like a traumatic brain injury than a stroke patient. And so that's another reason why we have our TBI providers see them. And so because our stroke service is split up by diagnosis, because people go to fellowships to work with certain diagnosis. So someone that did a spinal cord injury fellowship doesn't want to see stroke patients. And I don't want to see spinal cord injury patients. So I'm happy we do it that way. And then some of the things that we look at, every patient that I see, I look at these things. Are they arousable? How are they sleeping? Are they having agitation? You can have that with stroke. It's a little bit less than our TBI populations, but we still experience that, and I counsel people on it. I didn't have a slide on it because it's not as common with strokes, but we just talked about it a little bit because a lot of it can be behavioral modified, and we don't have to do a lot of medications for it. Movement disorders. Sometimes people with Parkinson's have strokes. And so we kind of have to talk about that because that can mean they have worse functional outcomes than someone that doesn't have that diagnosis. We do spasticity management, and that includes Botox injections. I do Botox injections in acute care. Education and resources. So, again, how Dr. Mulpour was talking about expectations of like these interventions, thrombectomy and things like that. It's the same with rehab. A lot of people don't know a whole lot about stroke. They know somebody with a stroke or has had one, but what does it actually look like? And so I spend a lot of time on consults, like really educating people about what stroke recovery looks like and kind of normalizing their symptoms because a lot of times family members are like, oh my God, they're sleeping all the time or their shoulder hurts. I'm like, hey, like that's a normal part of stroke recovery. Like we're going to work on that and it's going to get better. And one reason I love working with stroke patients is you get to see them get better. And if you can help normalize that for families, it goes so far. And setting expectations of like, hey, they're very, very debilitated right now. We're not going to walk out of rehab. Like, IPR is not to get back to baseline. And so that helps patients feel a little bit better about their recovery. And so when you say stroke recovery happens over a year, that's a whole lot different because in people's mind, they're like, oh, I'm going to be better in 2 weeks. And you're like, no, 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 no. This is a months of healing and processing. And it helps them to not feel so defeated when they get to the end of their rehab stay and they're like, I still can't walk. Because I've already told them, like, hey, you're completely hemiplegic. I don't really expect you to walk up out of here. We're going to work on wheelchair skills. You need to be building ramps, things like that. And then we also see patients in the outpatient setting. So if they don't qualify for IPR or don't need to go to any institution, we really set them up in our outpatient clinic. Neuropsychological testing, that is really important for people that want to return to work, especially with higher cognitive jobs. So teachers, accountants, any type of managerial position, they have a lot of cognitive things or thinking tasks that they have to keep in charge of. And kind of the number one things that get knocked out after a stroke that people don't think about all the time and realize is like time management and space organization. So, like, I have a meeting at 11. I have these things to do before 11. How much time is it going to take for me to do all these tasks and orient all these tasks? Which one should I do first? Those are kind of things that you learn as an older adult, and that executive functioning kind of gets knocked out first. And so we want to make sure that before patients go back to work, they know about that. And those are things that don't typically come up in your everyday life. Every now and then that comes up, but it's not something that you're having to worry about all the time. And so neurocognitive testing really lets us know how a patient's brain is functioning because we get imaging and we know where the stroke is, but we don't know how much compensation that they have. And so that really tells us, well, how has their brain healed? And so we typically do that after around 6 months to really give them enough time to really heal. Every now and then we'll do it sooner if we have someone that just like breezes through and is completely back to normal. We assess people for driving, we do equipment management, and so we do a lot in our outpatient visits. Ooh, sorry. Went too fast there. So arousal. And so the number one thing with arousal is the person sleeping? And so if you are checking someone's vitals every hour in the ICU, something's always beeping, someone's always there, they may not be sleeping. And so promoting good sleep hygiene and maximizing sleep is kind of our first start because if you haven't had a stroke, you're really sleepy if you don't get good sleep. And so we typically recommend melatonin first, 3 to 6 milligrams. We always try to go low and slow. Trazodone can be used sometimes. I didn't put that in there. Neurofatigue is also really common after stroke. And our number one medication that we'll use is modafinil. So if we kind of maximize someone's sleep, we know they're getting okay sleep at night, we try modafinil. We give it at 7 a.m. and noon, so that way it doesn't keep them up. We'll usually start at 100 milligrams and then go up. That's our typical if they're just sleepy. If you have someone with a frontal lobe stroke, or sometimes patients have issues with initiation. And so by initiation, I mean they're able to do tasks, but like getting started is difficult, or they can feed themselves, but they don't. That's more of an initiation problem versus a true like neurofatigue issue. They're awake, they just can't start things. That's when we would look at more amantadine to help with kind of that process. And you do that at 7 a.m. and noon as well. They have very similar dosing. Post-stroke depression is extremely common. It's very, very high, and it can also lead to decreased arousal, decreased participation, and everything like that. And so sertraline, it depends on what other comorbidities to depend on what medications we recommend. So if someone truly is just depressed, they don't have a lot of hemiparesis or anything like that, or a lot of muscle weakness, we would recommend sertraline. It's very activating and it can help kind of wake people up a little bit more. Fluoxetine has really good data for hemiparetic patients and increasing motor movement. There was the FLAME trial and a couple of other trials, but the FLAME trial is kind of the number one because it really looked at movement scores and not Rankin scores. The other studies looked at Rankin scores, which are a bigger picture versus truly just motor scores. And so Fluoxetine is really good for motor recovery and stroke. And then we'll use duloxetine for people that have neuropathic pain. So sometimes with thalamic strokes, they get thalamic pain syndrome, and we want to make sure that that pain isn't really causing them issues too. Then spasticity. This is kind of the big daddy of PM&R. This is what we get consulted for a lot. A lot of times, if patients have to be readmitted after stroke, you develop spasticity pretty quickly. In our study books, it says anywhere between 0 and 33 days of onset, but sometimes it can be a little bit farther than that. Spasticity is a very specific diagnosis. It is velocity-dependent muscle tone. So patients can have hypertonia, which is where hopefully I'm gonna try to see myself and go show you. So whenever you're kind of ranging someone slowly, it's hard to range them, that's more hypertonia versus spasticity. Whenever they're going really fast, you get kind of a catch and then you go. Or when you try to go quickly, you can't. That's more spasticity versus hypertonia. And so that is rated by the Ashworth scale. We use the modified Ashworth scale. 1 is just kind of an increased tone kind of at the end. You can have a catch. 4, it's rigid. It's kind of a contracture. You really have to do surgery for that. And so we really try to, with everything in PM&R, our number one kind of motto is an ounce of prevention is worth a pound of cure. And so if we can keep you from developing a contracture, that is like we've won in life, okay? Because it's very, very common. If you take care of patients with stroke or seen them, they'll get kind of stuck like this. And that is because you develop a flexor tone pattern in your arms where you bring your arm in, and then you develop an extensor pattern in your legs, which means your leg is out straight. That's how you get the spasticity the most in those areas. And the way that I like to describe that to patients and explain why, I say, if you back in ancient days and a lion was chasing you, you would want your arm in close and you would want to be able to put weight through your leg because you need to run away. And so that's kind of why it does. And we don't have a good example, a good explanation of why spasticity develops in those patterns. And so first, we try splinting and oral medications. There are only 4 FDA-approved medications. We have baclofen, dantrolene, tizanidine, and diazepam. Diazepam is really reserved for more spinal cord injury patients because benzos cause poor motor recovery after any type of neural injury or brain injury, so our TBIs and our strokes. And typically, your spasticity is much, much worse after spinal cord injury than some type of neurodiagnosis. That's not to say that stroke patients don't get bad spasticity, it's a little bit worse in that population. And so our typical go-to is baclofen. And we usually start at about 5 milligrams. If someone is like really, really sleepy, or the baclofen makes them too sleepy because it is sedating, it can also lower the seizure threshold. We'll do dantrolene, but dantrolene requires liver monitoring. So you have to have liver enzymes before and after, and we frequently check that in clinic. I have one patient that he's been on, usually it develops in the first 6 months, but I have a patient that's been on it for a year and he just now developed transaminitis. And so you do have to follow it regularly. Those medications are good for people that have more widespread spasticity. For someone that has like very specific muscle spasticity in certain muscles, or we have someone that gets really sleepy from the oral medications, because kind of all of them besides dantrolene cause them to get sleepy. We will do Botox injections. So Botox is botulinum toxin. I always have to look it up. I can hardly say it. I'm a Mississippi girl, okay? Big words are hard. And so we'll do those injections, and all it does is weaken the muscle. And so it's really important when I talk to patients about it and tell them, I am not giving you muscle strength. I am literally making it weaker. But our goal with the Botox is, the best example I have is your biceps and your triceps, they fight each other. And so one thing I love about PM&R is we are so patient focused. So you have some people that it's more important to them to be able to straighten their arm. So in that case, we weaken the bicep. We have some patients that it's more important that they flex their arm. And so you'd weaken the tricep in that aspect. And sometimes we do a little bit of both depending on what they need. And so Botox can be very specific. It is kind of a trial and error. And so I always tell patients like it's more of an art than an exact science. And so it's getting the right dose, the right muscle combination, and things like that for our desired effect. You can also do backlift and pumps, but we won't talk about that because I don't really see them a lot in stroke patients. Moving on. These are two of our prevention methods. We have the resting hand splint here. It kind of keeps their hand from balling up, and that is important for hand hygiene. If they are going to regain strength in their fingers, if they're able to get those finger extensors, but their hand is stuck like this, they can't use those fingers extensors. And so you put them in a resting hand splint to kind of prevent. Remember, an ounce prevention is worth a pound of cure. And then we have a phase 2 boot or a multi-POTUS boot, and depending on what the name at your hospital is, you can order it from Central Supply, or like we have O&P at our hospital and we'll order it from them. And this keeps your foot plant or dorsiflexed, so like this, because like I said earlier, your extensors take over, and so you get stuck in plantar flexion. So if people are learning how to walk, they're stuck on their tippy toes, and it takes a long time to stretch those out, and it's really annoying and it's hard. People are at an increased fall risk. They can't really wear a lot of shoes, and it's just very difficult. So if we can keep them from ever developing a plantar flexion contracture, again, we have one in life. Bowel and bladder incontinence. That is extremely common. 50 to 70% of patients have urinary incontinence within this first month post-stroke. And so for all of our patients that we admit with a stroke diagnosis to Spain rehab, we get post-void residuals the first 3 days. If they kind of get out of those, if you pass those, then we stop it. But we do catch a lot of urinary retention that is not caught in the acute care settings because we're monitoring it so closely. And so what we try to do first is we will do timed voids to see if we can promote continence, because continence is extremely important because that is the number one reason why families will not take a patient home. If the patient pees and poops on themselves and they have to have someone change them, family members are not really excited about that, and they don't want to deal with cathing, they don't want to deal with Foley's, and so they will send them to the nursing home until that gets better. And sometimes it doesn't get better, and that patient is promoted to long-term care. So we work a lot on trying to get people continent because, like I said, it's really important in their day-to-day life, and it's huge, huge, huge for families. And you can also get skin breakdown if you're not continent. You can get ulcers, which have their own cascade of effects. And so we start with a timed voiding schedule. And so that's really easy. You just kind of get the patient up or put them on the bedpan, or if it's a male, they use a urinal every 3 to 4 hours. I mean, think about how often you pee as a normal person, about every 3 to 4 hours. And so that kind of helps them get on a voiding schedule, because some part of the issue is that if you have an aphasic patient, they just can't tell you that they have to pee. They may feel it, but if you get them on a timed void schedule, sometimes that fixes the issue. Sometimes we have to do intermittent cathing. And a lot of times we'll add medications like Flomax or Bethanocol to kind of help promote if they're having urinary retention. Bowel incontinence or constipation can occur after a stroke. Constipation is a little bit more common just because they're not up and moving, they're on pain medications, or they are on a different diet. And so we typically do Miralax and Senna at lunch. Sometimes we even do like suppositories after bedtime. And so whatever we can do, because like I said, get people continent, because that's why people don't want to take them home. Post-acute stroke or post-stroke shoulder pain, it happens in 85% of patients. It is a huge issue. And actually, a really common reason that nobody thinks about is complex regional pain syndrome. There is a very specific diagnosis criteria. I cannot remember uh, the checklist off the top of my head. You can Google it. But a lot of times we do passive range of motion with PT. You can do steroids, NSAIDs, TCAs, things like that. But it has to have associated symptoms. So a lot of times people get diagnosed with it because if you're not moving a limb, you get swelling. And so the way that I describe it to patients is you are big bags of fluid. And where does the fluid go? To the lowest point. And if you're not, your muscles contract to push that fluid around your body so it doesn't stay in one spot. And so sometimes people are diagnosed with complex regional pain syndrome after stroke just because of the nature of the stroke and not necessarily because of they actually have that. And it's more due to edema. But if you have edema, sweating, vasomotor symptoms like erythema or skin changes or your hair stands up, then that is more leading to complex regional pain syndrome versus just edema. And then subluxation is also really common. I didn't talk about rotator cuff tears. That is also extremely common, or biceps tendonitis. That's very common after stroke just because those muscles hold your shoulder in place. Our shoulder is not very secure. The ball is not very secure in the socket to give you more range of motion. And so those muscles are in charge of holding that in place. And if you have a stroke and those muscles are weak, that head can sublux out. And so it's a really common cause of shoulder pain due to muscle weakness. Proper positioning with pillows, making sure their pillow is under their elbow when they're in bed at all times is very important. I make sure to educate patients' families about that because they're usually always in there. PKT taping can be used by the therapist to support the shoulder joint when out of bed. We also use these little slings. It's called a Give More sling, and it has a little bar down here. These are the most common ones we use for patients with hemiparesis, and it kind of supports the shoulder here. It kind of keeps it from sagging, but then it also gives their hand something to do, so it's not just kind of flying around because that annoys patients, and it has something for them to hold so they aren't kind of flexing up like this. So you'll see if you ever see patients after they leave RPR and they have one of these, it's called a Give More sling. And now to the big part of my talk is motor recovery. So like I said, this is the number one thing that people are upset about after stroke recovery and after I see them in the hospital. It's a lot of times the upper extremity. They're very upset that their hand does not work how it used to. And that is because the lower extremities typically come back first and recover more fully than upper extremities. And again, the way that I explain that is kind of just evolutionarily. Like if your leg came back first, you could run away from danger versus you have another hand. It also could be because some people are like, well, my hand is closer to my brain. Why wouldn't it heal first? And I'm like, well, that's very good logic, but that's not how it happens. You get the most motor recovery in the first 3 months after stroke. And so if I have someone that's on the fence about, oh, well, I kind of want to just go home, I don't really want to go to an institutionalized therapy program like IPR, I tell them you get the most recovery in the first 3 months. And so we really want to maximize that while you're inpatient and try to really work on that with modalities and such that you would not get as high of intensity if you were to go home and do outpatient therapy. And motor recovery begins with synergy patterns. And so, what a synergy pattern is essentially like a copy and delete for your brain. And so, think about when you eat. You don't think, oh, I need to flex my fingers, extend my wrist, radially deviate it, and then bend my elbow to bring food to my mouth. You just do it. And so, that is a synergy pattern because it's where many muscle groups work together for a common function. And so, motor recovery synergy patterns are also the same as with spasticity. So you develop your flexion ones first, and then your extensor ones in your arm, and it's the opposite in the leg. And as you get more motor function back, spasticity decreases. So it's really cool. And then some prognosis indicators. When I first meet someone right after a stroke, I can't say, like, hey, you're not going to recover well. We just don't have enough data. It's very, it's too soon. But if you have someone that at a month, so a lot of times patients have like extended acute care stays because of other medical issues. And so sometimes they are in inpatient rehab around that 4 week to month mark, depending on how long are there. And so if you don't have any hand grip by 4 weeks, you're probably not going to have a super great recovery. And so what I tell people about good recovery, what we call good recovery, is how well you do ADLs or activities of daily living. And also poor recovery, prolonged spasticity. And so if you don't start to develop spasticity or you're just like really like completely flaccid for more than 6 weeks to a month, you're probably not going to get super good recovery in that upper extremity or lower extremity. If you have a lot of proximal, so like shoulder spasticity, you're going to have a less recovery. And again, no measurable hand grip at 4 weeks. And so sometimes patients have a little bit, like you can feel the muscles contracting in their forearm. They may recover, but usually they won't. This is the predictable pattern of someone that gets better after hemiparesis. So it's a very predictable pattern, and we get tested on it a lot for our PM&R boards. And it also is great for you to talk to patients about. And so if someone has hemiparesis, you're typically flaccid. When they come in, that arm doesn't move at all. And then spasticity starts to appear. And then someone will be able to, the next step is you're able to move in those synergy patterns. And so what that means is you're able to, if you have spasticity, you're able to kind of flex your arm like this and extend your leg a little bit. Those are those synergy patterns that I was talking about. And then you start to master those, and spasticity gets less and less and less. And so then you can do more complex movements. Your synergy patterns lose their dominance. So then you're able to do more things with your arm, and then you lose spasticity altogether, and then you're normal. Not everyone goes all the way through these phases. So this isn't always how it happens. Sometimes patients get stuck in one of these phases. And it just happens to be like how severe their stroke was, other comorbidities, do they have prior strokes, and things like that.
Dr. Lopes,
Yes.
maybe 3 or 4 minutes.
Oh, okay, yeah. I'll go quickly then. So some of the things that we do to promote stroke healing is we have acute stroke recovery and long-term or chronic stroke recovery, and it's at 3 months. So 3 months, after 3 months, you convert into long-term recovery. So in acute care, we have functional nerve stim, and so we use electrical stimulators to produce functional movements. That just means you're doing it. Neuromuscular electrical stimulation, you're just stimulating the nerve to move. It can be EMG controlled. You can't do it with pacemakers. It has FDA approval. That's important because that means insurance will pay for it. You then have, this is devices moving into the chronic stroke. So after 6 months, patients can qualify for these devices. And so the IPSI hand uses EEG impulses and then causes your hand to contract. You have to do a lot of training for this, and sometimes patients don't qualify because they don't have enough EEG impulses to do this, and you have to have intact cognition. You have transcranial stimulation. Neither one of these are FDA approved for stroke recovery, which is important. So you have repetitive mechanical or magnetic stimulation, which is where you kind of apply magnets to the skull and it increases susceptibility of plasticity. You have transcranial direct stimulation. That is where you use electrical current with little saline sponges. And you either give an inhibitory or an excitatory electrical stimulation. And they have the best results whenever you stimulate both sides. You excite the injured side and inhibit the healthy side. These are not FDA approved, meaning your patients cannot take home these devices. They'll sometimes be used in therapy. Vagus nerve stimulators. UAB is getting a vagus nerve stimulator program we're starting it probably in the next year to get these devices implanted. They have to be implanted by neurosurgery. We don't have the superficial ones. It does have FDA approval, so that's why we're getting it done. And then you have to make sure to implant it on the left side because the right vagus nerve goes to the sinoatrial node. And so it helps with motor recovery after a stroke. And these are kind of pictures of what these look like. So you have, this is the magnetic, this is the electric, and then this is the vagus nerve stimulator. Take home points. You do get motor recovery. It can be facilitated. We're here to help. So if you have questions, reach out. These are my resources. And then this is my cute family. So thanks.
Thank you. Yeah, thank you, Dr. Lopes.
Yeah.
Yeah, we have one question in the chat box actually. Dr. Raj, he's asking about, I think it is for Bagi, thoughts about respective LDLs, goals between different guidelines. Example, the European Cardiology Guideline and recommendations. Can you read that, Bagi, in the box? Are you there?
I think it says what are the recommendations for the goals, because the European guidelines are stricter and the Canadian guidelines recommends a lower non-ND HDL. So they don't follow LDL, they follow the lower non-HDL.
I'm not aware of those. I mean,
Bagi cannot mute himself for some reason.
Uh, it's not working. He couldn't mute. He couldn't unmute. That's what he's texting.
It's Vijay.
Uh,
Okay, can you hear me now?
yeah, we can hear him.
Okay.
You're the co-host.
Yeah, I'll answer it a couple of ways. By stroke heart association guidelines, the answer is there is no data on it. But what I think is important in this is if you understand stroke etiology, kind of what I talked about, if we think it's a stroke due to atherosclerotic disease, that kind of thing, not an embolic stroke, I think it makes sense it's beneficial to adhere to lower target and maybe beneficial. So that's what I would say. If it's a stroke etiology due to vascular risk factors, atherosclerosis, I think it probably makes sense. If it works in the heart vessels, it probably works in the brain vessels too.
Yeah, that's what you were saying when you individualize. If you see atherosclerotic plaques,
Yeah.
you would
Now,
be.
if you have atrial fibrillation and a truly embolic clot, probably don't need to go to such a low guideline.
Dr. Lopes, about almost a decade ago, there was a study that if you tie up the good arm and make the paralyzed arm work better, I mean, do they recover any faster? But I don't think it was substantiated during subsequent studies.
Yeah, so that is constraint induced movement therapy. So one of our physicians actually studied that. Dr. Victor Mark, he's the F&D guy. It's more for chronic stroke, so it's not really for acute care stroke. And it has some good evidence, but it's hard for patients to do because you have to bind it up for the majority of the day. It can't be just when you're in therapy. And so a lot of patients get very frustrated with that. And so while it has good evidence, it's hard to practically do because of just how long you have to have it tied up.
Thank you. Bagi, I know you didn't mention about I mentioned about the permissive hypertension, but you already went ahead it is taken care in the ER with a bolus and in acute stroke management. You want to enlighten a little bit of that too?
Yeah, I'll talk about permissive hypertension. And again, it's a little bit individualized. Not every stroke needs it, but if you have some degree of stenosis, I mean, all permissive hypertension is doing is we're trying to augment blood flow. But if your arteries are wide open, it's not going to help. But if you have carotid stenosis, vertebral artery stenosis, intracranial stenosis, those are the patients who it helps. Other people who it helps are clinically. If they're behaving in a certain way when their blood pressure is lower, they have more deficits, or when their head of the bed is up, they have more deficits. Those are people who permissive hypertension helps. But it doesn't have to be done on everyone, though.
Okay. Yeah. Dr. Vasavada is asking in this question. I mean, 3-hour therapy.
3 hours.
Why 3 hours? And I have
Yeah.
heard somewhere where people do a lot of synergetic movements, they get better, but I'm not sure if that's true or not.
Well, the synergetic movements, it's just how your brain recovers. And so sometimes that's all they can do. And so it's not necessarily that that's what makes them better. It's that's all they can do at that time in their recovery. And 3 hours, typically, it's because you have to have an hour of PT, an hour of OT, and an hour of speech.
Oh, okay.
If it's a little bit less, and then some patients, if they don't need speech, they get an hour and a half of PT and OT. It just is 3 hours. It's averaged 150 minutes a week is really what it is. And so that's 3 hours a day, 5 days a week. But as far as who picked that, I don't know.
In fact, one of our, in our hospital, at least, if they walk 100 feet on their own, they go to outpatient rehabilitation. If they cannot walk 100 feet on their own, that's at least one of the social worker who screens for the inpatient IPR versus outpatient rehab. She told me
We
long
look
time.
at how good is that walk? Are they really needing a lot of assistance with that walk, or are they using an assisted device that they didn't use before? And then a lot of times, if you have someone with a big left NCA stroke, their speech deficits are so bad it then bleeds into their OT deficits or their activities of daily living deficits. And so a lot of times, sometimes, and also with right NCA strokes, their neglect is so bad, even though they walk okay, if you just let them go on their own, they are going to run into the wall. And so a lot of times they'll qualify because of that. Even if they walk 100 feet, if it's really ugly, you can still qualify.
But we have people coming in the hospital with evaluation from one of the private rehab here in town. And so they do, I think, good evaluation, and hope they do well there. So, but this is a really debilitating disease, and the depression is so common too. I see that very often. Sometimes I remember earlier we used to use older antidepressants, and they were still, I think, more effective, but we don't use it anymore, nortriptyline and stuff. And then Ritalin, also low dose of Ritalin. When I worked at that rehab, I used to use some low dose when the sedation was so much. Not Adderall usually, but Ritalin, but not sure if you
We'll
use
use
that.
that too.
Yeah.
But typically, a lot of our stroke patients have cardiac disease, so they would want to use it. We use it more for our TBIs because they're usually younger and healthier and don't
Yeah.
have multiple heart attacks.
I had one patient, one young lady with a basal ganglia stroke. I mean, she was wheelchair bound, and actually, I had to put her on some dopaminergic medication, Cinemat actually,
Hmm.
and she did fine too. Actually, it's an anecdotal, but because of the location, I used it. So
Yeah,
Mhm.
and sometimes that happens. Basal ganglia strokes are also pretty bad. They have a lot of motor deficits.
yeah. Uh,
Any more questions? We can finish
I'm
it.
not seeing
Amit is
any
still
in the
around
box.
or not? Not sure. Let me text Amit if maybe he's
I'm
gonna
not
be.
seeing anything in the chat box, but
Yeah, I'm here. I'm here.
Oh, Amit is here.
Yeah,
Okay.
yeah, I'm here. Thank you so much for the wonderful talk. And I learned a lot, and though hopefully I'll never come across that kind of patient, but we see a lot of patients who have neurological problems after stroke, and that's another issue, which neurogenic bladder is a well known thing, which is a management challenge to people, especially if they have other prostate problems, etc. So, great talk, and I'm absolutely encouraged. And I think that a lot of people have actually commented elsewhere to see these young people give such a wonderful CME. So, Tarak, the thing which we need to think upcoming CMEs. Let's get YPs involved more in doing these CMEs rather than
Mhm.
others. So I think I will. In fact,
Yeah.
I actually sent a text to Gautam, the YPS president, to let us.
Yeah.
Um,
Maybe you should assign them a CME that they can come
yeah,
up with. Young people will do a better job than we do,
yeah, it's not a better job. It's just like a
but
different
there's different
perspective,
perspective. They know more.
and
Yeah.
they
different
know.
perspective.
I mean, they are young. They're full of knowledge, and also we make think about a a hybrid. Have somebody older who can give experience, and have somebody younger who can give the newer perspectives, and we can have a
A
combination
combination
of
would
them.
be, yeah, that would be
Yeah,
great, actually.
that'd be great. So I think that's a great talk, and thank you very much for doing this. And I I wish you guys all the best in your future careers. And if there's no further questions, we may conclude here. And thank you
Yeah.
very
Please
much
come
for
back next month. Like I said earlier, third Sunday, and it'll be
yeah.
three CME talks: sudden cardiac death, hair loss, and even how to manage some of the hair loss issues. And then we will have it one on the long-term COVID issues. So three talks is a potpourri of the different CME topics. So I really sincerely thank Dr. Lopes and Dr. Buggy. Buggy is on call, but still hanging around. And I appreciate it. And Dr. Lopes, you really enlightened me a lot about the rehab because we all refer the patient and then not look back
You
and
don't know
why
what
and
happens.
how it happens and what are the criteria. And so this was really,
I,
really good. That
I had a question which I don't know whether it pertains to this, but just like, are there any things which if a person is predisposed to stroke, what makes them predisposed? Or more importantly, like we have calcium score and CTA to diagnose or anybody, even asymptomatic persons, would they have would they're predisposed to having a MI? Do we have any such tests for a person who wants to rule out his chances of getting a stroke? Is there any test like that?
It should be for buggy.
Yeah, we really don't. I mean, there's new trials on asymptomatic carotid stenosis, all that came out, but there's no role of like right now how the cardiac doctors do a chest CT. There's no role for CTA screening or anything because overall asymptomatic stenosis is a bit more complicated in the cardiac world.
There you go. I think that's something which you need to start working on,
Yeah,
Bagi.
we need to work.
Bagi, start working on
Whatever
that.
is good for the heart, it probably is good for the brain too. I mean, maintaining the good lifestyle.
True,
That's
true.
what he mentioned, the lifestyle.
No, I mean, can we safely say that if a person has a negative calcium or very low calcium score and maybe had a CTA which was considered clean, will that person also can we say that that person has less risk of having a stroke?
Yeah, I mean,
No,
this last week, the biggest trial on asymptomatic carotid disease stenting was positive. So there'll be more of that, but no one's gone. Maybe the next step is and then they start doing screening more from CTA head neck. But right now, it's pretty early. But that is, I mean, if I looked at the CTA on somebody, I would have a pretty good idea on what their stroke risk is, but it's not proven yet, though.
Great.
Thank you.
Thank you so much.
Thank you,
Appreciate it.
guys.
Uh-huh.
thank
And we'll
you.
see you in a month again. Thank you.
Thank you all.
Bye.
Okay, bye.
Thanks, you all.